Hi, my name's Jo Gibson, and I'm a clinical physiotherapy specialist working in Liverpool in the UK, an limb rehabilitation specialist. That's my new title in the new clinic that I'm working in. And as ever, I'm here to share some shoulder nuggets, some patient examples with you on our Facebook Live tonight. Now, I was away last week lecturing in France, which was great fun. And we had some patients during the course, which gave me a real opportunity actually to reflect on our communication, which clearly we know is central to the success of our interventions, but actually one specific part that perhaps gave me clues that things weren't going quite as well as I thought they were. So I'm going to tell you a little story about this particular patient and why, in myself, I felt fairly confident. I knew what the issue was going to be, what I was going to do about it. And then when perhaps things started to go wrong and what made me think they were going wrong, and importantly, kind of what the outcome of that was and how we got it back on track. So, as we know, communication in our therapeutic alliance is central to everything that we do. So, sometimes when I'm teaching, I get asked if I'll do patients on the course, and I've always been a little bit reluctant because it's a very unusual situation. And what I really value in the clinic is having that one to one, if you like, where it's all about the patient and nothing else. And generally on the courses, if I do see a patient, I don't talk about my clinical reasoning process, etc., while the patient's there. I just go through the process and then afterwards have a debrief with the group. Now, the particular patient in question came in. It was in another country, so it was clearly being translated. The patient did have pretty good English, but we decided that she'd talk in her native language, so the nuances weren't lost, and then that was translated back to me. So you can imagine the communication's already potentially a little bit more difficult. But it all seemed quite straightforward. This lady had a really clear history where she'd done more than she'd done previously. She was very active, very sporty, had had a period of time where she'd just suddenly done lots and then got some anterior shoulder pain. So it sounded pretty much like it fitted the picture of a fairly straightforward tendinopathy. Now, this had resolved on its own, it had gone better, but then she'd had a lower limb injury, she'd had to be on crutches for a while, not been able to do her sport, and then this pain came back. And rather than going away on its own, this time it stayed. It was starting to cause problems with her other sports and the things that she was doing, but also she worked at a desk, so she had a very sedentary job, very active sports. And so basically, this anterior shoulder pain had started to get a little bit more irritable. And so she was getting some issues just relating to sustained postures at work. Now, in terms of my examination, she had some neck stiffness, she had some tenderness over her biceps. It was very easy to change her pain with some simple symptom modification. Treating her neck again improved her symptoms. So there was lots I could share the group. But what was really clear as we were going through the process of me improving things, of changing things, of trying to explain as we went along, is this patient wasn't entirely engaged. Now, at the beginning, when we were sat down and she was telling me her story, and it was kind of her, me, and the translator talking, she was really engaged. She was really smiley. She seemed very on board for the whole experience. And again, when we started doing things again, she was engaging, but it just became very aware, particularly when I was talking to the group, that she was kind of turning her body away a little bit. Her eye contact was changing. She wasn't maybe smiling quite so much. And it became clear to me that whatever I was doing wasn't resonating with her. So I kind of changed tack a little bit. We did some different things. We got a few more smiles. We got her doing some exercises. And I kind of demonstrated what I wanted to in front of the group. But for me inside, there was still this real feeling that I hadn't quite engaged with this patient, but also importantly, there was something more I needed to know. Now, when I do my initial assessment, I always ask patients what their understanding is of what their problem is. And this girl had already decided she'd got a tendinopathy from what she'd been told. And the reason she'd been told we'll come back to, because that was pretty important in this whole story. Um, what they've been told, what their expectations are of me, what they're hoping I can do within the session, and if they have been told things by other people, what does that mean to them? So I'd kind of done all that, um, but in retrospect, perhaps hadn't pursued it quite as much as I should have done. Anyhow, we finished the kind of practical session. The group went off for lunch, and I said to this lady, "Do you mind hanging on for a few more minutes so that we can have a conversation?" And check that what you've got out of the session. And she was kind of happy to do that. Now, at this point, she'd kind of got quieter. She was interacting less. Um, so I asked her what would be helpful for me to talk about. And as I say, her English was pretty good. And she said, "Well, I will need to understand what you think the problem is." So I said, well, I think what you've been told in terms of a tendinopathy was a really good original explanation. And this is the reason I think the pain came back. And this is the reason I think it hasn't gone away. And importantly, these are the things I think we can do about it. How does that make you feel? And then from nowhere came this story that essentially she said, well, the thing you don't know and we haven't talked about is this cracking I get in my shoulder. I get cracking in both shoulders. It's painful in the one where I've got this anterior shoulder pain. It's not painful in the other, but I'm really worried that I'm going to get arthritis. Now, it turned out that she had a close friend that was a physiotherapist. She'd had all this cracking and clunking noises in her shoulder, and she'd mentioned this to the friend who'd gone, whoa, stop doing that. That's really not, that shouldn't happen. Now, that's not necessarily what that person said, because remember, if patients are scared, their filters, their auditory system is just like any other sensory system. It filters according to previous experience and our fears and our anxieties. But essentially, what she heard that was because she got this cracking, she'd got a high chance of getting arthritis in the future. Now, this hadn't come up in the assessment at all. And so there's really two key messages here. I think what I really learned was one, my intuition was I hadn't engaged, even though this patient was saying all the right things in terms of, yes, she was happy, yes, she understood, yes, I'd answered her queries. Her body language was not telling me that. From being quite smiley, quite open with her body language, almost mirroring me, eye contact, all the things that we know are associated with good interactions. Those things started to dwindle a bit as the session went on, in that she got a bit more fidgety, she was turning away, she perhaps wasn't, the smile wasn't reaching her eyes. There was a little bit of defensive behavior where her hand was kind of across her chest and crossing her arms. Now, it was very cold in the place we were doing the assessment, so we have to put these things into context, but it just became clear that perhaps there was a backstory. Now, obviously, the backstory was she was very worried about this pain. The fact that the second time it had come and stayed with this cracking that was painful, her big fear was she'd started with arthritis and it was going to stop her getting back to all the things that she wanted to do. So you can see some very simple things can really then underpin a massive barrier to success, in that if I hadn't got to the bottom of that, this girl would have gone away thinking, well, you haven't reassured me about this cracking. She hadn't told me because I probably hadn't questioned well enough. I could easily blame the language barrier, but I should have pursued that story a little bit more. Now, when I was just looking at whether I'd talk about this to you guys tonight, I was thinking, well, what are some useful messages to take away from this? The key thing is we're always told that communication, well, I'm a great advocate that communication is our superpower, and that's the skill that perhaps we need to invest in most, because there's no doubt an effective therapeutic alliance underpins everything that we do. But when I was looking at nonverbal communication, particularly, the great thing is that we hear a lot about language. We hear a lot about how we as clinicians need to be really careful with the language that we use. But what's absolutely clear from the communication literature, it's more about how we communicate often rather than the words themselves. So if you like, you can, let's say, we're trying to say that we're interested and we care about somebody. But if our body language is looking disinterested, looking at our watch, looking at something else, the non-verbal cues will actually win out. And when we look at their power in communication, actually non-verbal communication can account for 55% of the effectiveness of our communication interactions. Now, there was a really lovely model, the empathy model, so EMPATHY with little dots in between, that was actually set up as a learning model and a kind of tool, if you like, to help clinicians get better in terms of rating their own non-verbal communication. And I'll post a link to this on the Facebook page. It's a really nice, simple summary, if you like, of what they did. And this was in Massachusetts at the General Hospital. They developed it and then did some research showing its utility in improving non-verbals and patient interactions. Now, the empathy, the E stands for eye contact. Interestingly, within this model, they decided not to use touch because they found there were massive cultural differences in terms of what touch meant. Now, you could argue the same thing in terms of eye contact, because again, whereas in Western we like eye contact as long as we don't gaze too long, inappropriately long eye contact is actually a negative thing in certain cultures. So we do need to be slightly conscious. However, eye contact is the first part of empathy. So you can imagine just sitting and being at eye level with somebody and looking interested is the first thing in successful nonverbal communication. Now, again, these things are very simple, but it's just nice to have a reference, a framework, if you like, to self-check our own practice. Because again, if you don't have a self-check reference, how do you know if you're doing it well? So the E was obviously our eye contact. The M is muscles of facial expression. So it's making sure your face is backing up what you're trying to say, looking interested. Interestingly, head tilt is a very effective way of showing that you're listening to somebody, smiling if it's appropriate. Again, mirroring is a very effective tool, but using that again in context. So it's very much in line. If you're matching your nonverbals with what you're saying or what you're hearing from the patient, then those things amplify those responses in the brain. And we have really great research to back that up. Now, we've had our eye contact, our muscles of facial expression. Can you guess what the P is? The P is for posture. In terms of posture, again, we know this is a really powerful signal in terms of positive and negative emotions, independent of those facial expressions. And what was interesting, some really nice research that I was reading earlier today showed that when they looked at one of the most effective things relating to patient satisfaction of therapeutic interactions, it was no more complicated than the clinician leaned in, which was perceived as them being interested in taking more note. Now, we know these things can actually have a very negative context. We have all sorts of cool research looking at the posture you adapt when you walk into the room, or the posture you adopt with your patient. But in the instance of this girl, I can use it very positively to lean in, to look interested. But if she starts leaning back or turning slightly away, these can all be early warning symptoms that she's not liking what I'm saying and she's disengaging because it's become less relevant to her. So that's sitting down at eye contact, a nice open posture, something that conveys mutual respect, very, very powerful in our nonverbal communication. Now, the A in the empathy model is affect. Now, again, although most nonverbal communication is subconscious, actually, this conscious or awareness of a patient's emotional state, if you like, and how they're responding to what we say is massively important, again, in establishing that therapeutic alliance. We're all constantly sense checking if what the patient is saying to us is matching with how they're behaving and how we're responding to those different nonverbal cues. The T in empathy is tone. And again, what's really fascinating with tone is very dominant, almost patronizing tones are highly correlated with litigation. So if you look at lawsuits that have been filed by patients, they're highly correlated with the way in which the message was delivered in terms of tone. So again, with our patient, if we think back to my patient example, a change in tone can be another warning symptom that the patient's perhaps not happy with what you're saying, whether it goes up, whether it goes down, whether it gets faster, whether it goes slower, that it changes from that initial interaction. Now, the H was hearing, and that's hearing what the patient's saying, and whether, again, that matches with what they're telling us, and being able to mirror that, again, is very important. And finally is our response. So the Y is for your response, so the clinician's response. And I guess for me, this was the bit that really wanted me to share this with you tonight about this particular patient, because overwhelmingly throughout the interaction, I'm kind of trying to do my confident clinician, conveying this to the patient in front of me, making it relevant to them, continually chunking and checking and reflecting it back to them, but all the time aware that perhaps something wasn't quite right. Now, as I say, the subtle clues for me were she got a bit more fidgety, she was pursing her lips, even though she was saying to me she was happy with what I was saying. That smile wasn't quite reaching the eyes. She put her hand over her neck a couple of times, which can be a defense mechanism, or if somebody's a little bit anxious. So again, we've got to put it into context. She was trying to talk to me in front of a big room of people. But I think really the reason I wanted to share her tonight is that, one, we're given a really hard time about being careful about our language. If we say something and we see a negative response in terms of the patient's nonverbals, the key thing is we just have to check what that means to them. So we hear about the Kieran O'Sullivan test in terms of how are you going to explain what I've told you today about when you go home, your partner, your wife, husband, whatever. If they then tell us something that is wildly apart from what we said, again, that tells you masses about what their filter system, and actually probably highlights a lot in terms of their fears. So for this girl, it was kind of, look, you're saying that you're happy with what I've said. Are you really? How do you feel about what we've talked about? And using feel, so again, these very emotive words that again suggest I've heard something, have been shown again in the communication research to really increase the likelihood of a patient telling you what matters. But the bottom line was, we sat down, it was just the two of us, everybody else had gone. I made sure I was sitting in an open way. I was leaning forward. I was looking interested. And the other thing that was really interesting that came out of this study that looked at the things that influence positive satisfaction was gesturing. So if I lean in and I gesture as I'm talking and being expressive, again, that seems to highly correlate with patient satisfaction. So you can see there's some really simple things that I can manipulate to kind of get this patient back on board and try and get things back on track. Now, importantly, she then told me all the things that mattered. But for me, and a reflection and why I wanted to share this was just trust your instinct. If things aren't going well, and particularly even if you, because I was getting a great response with this girl, and yet it wasn't making a difference to her. Those unsaid fears, those undiscovered beliefs are a massive barrier in our ability to change somebody's pain intervention. So she would, if I hadn't had that conversation at the end, she would have gone away, and probably not done the exercises and probably thought, who was that mad woman from the UK? She didn't really listen. She didn't understand what I was scared about. So why would I do these exercises? So it was a great example of, we can worry about the best exercises, we can worry about the best interaction, but actually some very simple things about our communication and really getting to the nub of what matters to a patient really matters. However, they need to trust us. And maybe she wasn't really ready to tell me. Maybe going through that process then made her feel more confident to tell me the thing that was worrying her. But fundamentally, if I hadn't been aware of the change in those nonverbal cues, the change in her tone of voice, the change in her body language, then I could have very happily patted myself on the back and thought, great, I've changed her pain, I've done my job. I very clearly hadn't. So, guys, I hope you've taken some useful things for that. As I say, it really, for me, this was a bit of an indulgent reflection. But when I think how it made me feel in the clinic, I think it's really good to share that sometimes things don't go well. And I'm such an advocate of communication. It was a great lesson to me, one, to do what I usually do and make it all about the patient, stop explaining to the people that are around there. But two, how picking up those nonverbal cues is massively powerful in helping us know if we're on the right track or not, and giving us an opportunity to revisit things when perhaps they aren't. So I kind of really hope you've taken some useful things away from that, because to me, I found it, very leveling in lots of ways, but also very positive, because it made me kind of think, yeah, but there's a whole lot of stuff that we can do really well as well. Now, I'm desperately trying to get onto the chat here because I've heard all sorts of lovely clicks and pops. Let me just see. My computer's not behaving at the moment. Thanks. Just keep those coming, guys. I'll get to the... Oh, here we go. I found it. Let me just put my glasses on so I can read this. Thank you, Tim. Lose harder with a mask. Absolutely. I think in terms of it's really interesting. I've got this fabulous book, which is my communication go-to. I don't know if you can see that, Skills for Communicating with Patients. And that does talk about the problems, one, of digitalization, in terms of we can be sitting, typing at computers, we turn away. Actually, that increases the time in consultations because often patients will pause and wait. In terms of masks, again, you can think of the limitations and why we have to use our eyes and our gestures and our tone of voice much more effectively, because we can't use those facial expressions. We can perhaps overcompensate in terms of using those lean-ins and those tilts of our head, and just think about those a little bit more, because obviously we can't use our mouth to kind of reinforce some of those messages. So really make sure that smile gets to your eyes if it's an appropriate smile. But a really good point, Louise, in terms of the current challenges wearing masks. Neve, lovely to have you here. I'm very well. Thanks for joining. Tim, Glenn, Therapeutic Alliance is a powerful tool for us all. Glenn, I couldn't agree more. And that's probably a fabulous way of summarizing this evening. I'm well quoted for saying that communication is our superpower. But I think what's fascinating about this sort of research and this sort of patient is we often think of communication as what we say. Actually, our most important tool is our active listening and our effective use of nonverbals, and building a therapeutic alliance where a patient trusts us and feels confident to tell us the things that really matter to them. So, Glenn, thank you very much for that. That's a really lovely way of summarising the session. So, as ever, guys, I've gone over my 15 minutes. A lovely message from Neve. So, as some of you will know that join us for the Facebook Lives, I left the hospital about 4 weeks ago. I miss everybody horribly, but I can't talk about that because I'll get emotional. But new adventures to be had. So hopefully I'll be catching up with the guys for my official leaving do very soon. But folks, as ever, thanks so much for listening. It's always a great privilege when people give up their time to listen to me. But I just thought those reflections might be a nice, simple way of reflecting on the things that really matter in our communication, and just one very small part. Amy, thank you so much. Love this. My communication module at university was very informative, just like this. I couldn't agree more, Amy. I'm getting all these lovely miss you messages. I'm going to start wailing on the Facebook Live in a minute, guys. Thank you so much. But Amy, I completely agree. It was absolutely a game changer for me. I did a communication module as part of my master's. It was not an altogether painless experience because I thought I wasn't too bad at communication, but I realized I was thinking about communicating rather than perhaps listening, and how powerful my not just my nonverbals, but that building of that therapeutic alliance was in influencing somebody's pain experience. So thank you for that too. So I'm going to leave us with Glenn's therapeutic alliance is a powerful tool, that communication is our superpower, and that I work with some absolutely amazing people who I miss more than you know. And before I start crying, I'm going to finish the Facebook Live tonight and look forward to joining you all again next Monday at 7 o'clock. Thanks so much, guys, and see you again soon. Bye for now.